Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, July 11th, 2024, we are speaking to Dr. Peter Chin-Hong, who is Professor of Medicine and Associate Dean for Regional Campuses at the University of California, San Francisco School of Medicine. Dr. Chin-Hong is a medical educator who specializes in treating infectious diseases, particularly infections that develop in patients who have suppressed immune systems, such as solid organ and hematopoietic stem cell transplant recipients. He's the founding director of the Immunocompromised Host Infectious Disease Program at UCSF. Dr. Chin-Hong has received several teaching awards, including the UCSF Henry J. Kaiser Award for Excellence in Teaching. Today, he joins us to review the latest information on emerging infections. Peter, welcome to the podcast.
Thanks for having me on, Mike.
Yeah, it's great to see you. And we're going to go through, I think, just two emerging infections because they're the ones that I think are affecting us kind of the most. And that'll be a brief update on COVID. Where are we? And what's all this fuss I hear about measles? So let's get started. So COVID, it's now been it's over 4 years. That's hard to believe, but we're coming out of it, but we tend to dive deep again. Just a general statement about where we are right now in the general epidemic.
Well, COVID is raging right now in the United States. It's disrupting a lot of family reunions and weddings, music festivals. And we thought we would be over with it, but unfortunately, it seems to have a bimodal distribution now. Increasing cases in the summer and a larger increase in the winter. We've seen wastewater go up first. It was actually first in the West Coast. And then right now we're seeing cases in the community. Test positivity is up. Admissions are a little bit up. If we were talking about this in 2020, Mike, we'll be talking about ICU beds. In 2024, we're talking mainly about emergency room visits and urgent care visits.
And it's harder for us to track the epidemic because of the home test, right? So, in other words, somebody gets it, they may not report it or it won't be reported. ER visits we can track, hospital testing and urgent care centers. So what are the other ways that we can sort of get a sense of what's happening in the general community?
Well, I think everybody's darling now is wastewater epidemiology, or stuff you can look for in the poop. And, I think that that's really the canary in the coal mine. It's kind of the early warning alarm. We see that go up, and then we see cases in the community. We can certainly look at ER visits, like you said. We can look at hospitalizations. There's still some hospitals reporting. They're not mandated to report, but we can get a look at that. And of course, we hear these stories from people, our neighbors, our friends, things that are canceled, people who can't make dinner reservations, and staff in restaurants that are, homesick.
Yeah, the biology is kind of staying the same in the sense of the Omicron variant is still dominating, which eliminates some of the monoclonal antibodies that we used to have. There's one now that can be used for prevention among the severely immunocompromised, especially those on CD20 or rituximab B cell sort of inhibitors. How are you using that particular monoclonal antibody now?
Well, I think it's a great option for people who are very immune compromised. I think in the United States, there's been a narrative of just immune compromise, and a lot of people get thrown into that group, like people with diabetes, people on biologics. But for something that where you need to be hooked up for an IV for an hour of observation, we are really focusing on the very immune compromised people on B cell depleting agents like rituximab, people who are just after a solid organ transplant who weren't vaccinated before, people who have graft versus host disease, and people who are anxious. I think people think that we have strict criterion, but if somebody's locking themselves up at home because they're afraid to go out, I think it's reasonable, if you can't find antibodies in a test, to really offer it to them as a source of solace.
Yeah, and I think what's important is that for everybody to remember that this is not a treatment per se, at least it's not approved for that, but it is used for prevention, and it's given about every 3 months, if I recall correctly. But if that's really a specialized thing for the patients who are being treated with significant immunosuppressive type drugs, and I think we can just leave it at that for them to take that up with their doc. The Omicron variant is still dominant, as I said, but it's got new variants. I think it's called KP3 now. Does that matter to the general public or to the docs treating people besides the monoclonal story?
It doesn't really matter, but the main concept is that things are changing rapidly. And there have been a lot of anecdotes recently of people with more severe illness. It doesn't drive them to go to the hospital, but, sore throat, like razor blades, things like that. And in one case, for example, I think it may illustrate why this might be happening to your average person. So I knew somebody, for example, who got a lot of vaccines early in the pandemic, hadn't 2022 was the last shot, hadn't gotten any vaccines since then, but and also was lucky to not get infected since then until 2024 with these flirt variants. When they did get infected, they got a lot of symptoms. And I wonder whether or not, as the virus changed and you didn't update either by infection or by a more recent vaccine, the immune system is just a little bit more sluggish. And in the meantime, with increased, transmission, reproduction of virus in the body, you're just going crazy and you're getting all of these symptoms. So, I think symptoms are variable, and COVID for some people is still no walk in the park, even in 2024.
That's right. And so I don't know the age of the person, but what did you recommend, or would you recommend to somebody like that, even if they're in their 30s or 40s? Would you recommend antiviral therapy early, like Paxlovid or Molnupiravir?
I think in the early days of Paxlovid, we were thinking about it for everyone, but as the immune sort of status of the population increased over time, we're becoming a little bit more selective. Of course, we know about data in people under the age of 50 and younger, where it doesn't seem to really make a difference when you look at the studies. But I think, if you look at the lowest hanging fruit, is those who are older than 65, who are very immune compromised, drug interactions notwithstanding, and who haven't been recently vaccinated, where I'm not really confident that, they won't get seriously ill. I think of that population as the lowest hanging fruit. That's a population I think we should really chase after in terms of Paxlovid. And even before that, have a Paxlovid conversation, think about drug interactions, figure out how they're going to pay for it. It's right now in the free market. People have been saddled with $1,300 bills, but there is a website, Paxess, Paxcess, where even people without insurance can still get the drug, but not many people know about that.
Yeah, I've been routinely recommending it for those over 60. I mean, we can pick a date, but the key thing that I think the docs need to remember is that if you're going to pull the trigger on that, pull it relatively early. Don't wait till severe symptoms are happening or more severe. And there is concern in the past about Paxlovid or viral rebound, but I think the more recent data show that that's really not an entity, that you get recurrence of symptoms in about what 8 to 10% of people anyway, and it's not really a rebound. Is there anything new or different about what I just said?
No, except that more and more studies are showing really more, equivalence in terms of whether or not you take Paxlovid or not. You can still have rebound, and don't go checking for it unless you have symptoms. I think the
Right.
other
And
pearl
don't,
about Paxlovid might be that, again, like you said, I think the point about not waiting for symptoms is a good one, because even in that at-risk, vulnerable population, an older person who hasn't been recently vaccinated, for example, um, people don't really get sick for COVID. They don't fall off the cliff until about day 7. So saying you're waiting for symptoms is kind of a myth, because again, you're going to miss that window where you may have the biggest impact in within 5 days.
Yeah. It reduces severity of illness and also somewhat reduces transmission. And so those are good reasons. Before we move to the measles story, quick advice to kind of everyone about vaccination, when to get it again. You mentioned your friend who missed it for a year or two and got a more, maybe a more severe case. So, what would you recommend in the coming months?
So what has been really shocking for me, Mike, is that the vaccine uptake since the fall of 2023, when we had the latest version of the COVID vaccine, has been so poor in the United States. But what keeps me up at night is that it's poor even in the people older than 65, and particularly communities of color. I felt like we kind of dropped the ball on that age group, and everybody's kind of floating around feeling super complacent and confident. So with that said, the way I approach it is very simple. uh, an older person says, should I wait till the fall or should I get it now? COVID again is raging in the community right now in the United States. I'd say, did you get it since it was released in the fall of 2023? Yes, no. If you haven't, just go ahead and get it now. You're not going to wait, get it as soon as it comes out in the fall for the new vaccine. You probably want to wait until October or so before you get it anyway. So that's the way I would approach it. And of course, we know that the CDC has recommended or is allowing people older than 65 or those who are immune compromised to get, they can get a second shot if it's been 4 months or more since the last shot. And of course, immune compromised folks can actually theoretically get it every 2 months if they really wanted to.
Right. Okay, the other emerging infection is measles. Um, First off, a lot of folks, especially if they're not physicians, don't even maybe even know what that is because we didn't see many cases when we were growing up because of the vaccine. So, just a brief overview of what is measles.
So measles is a virus. It's probably one of the most transmissible infectious diseases we know about. Somebody could have measles in a room, leave the room, and then you go into that room 2 hours later, and if you're susceptible to measles you can catch it. One person with measles can transmit to as many as 9 out of 10 susceptible people around them, so something to truly respect. And what also makes me respect this virus is that before the vaccine was rolled out in the United States and around the world, it caused millions and millions of cases all around the world, and thousands and thousands of hospitalizations and deaths, particularly in kids under the age of 5. So definitely nothing to dismiss, and it's making a comeback. Who would have ever thought that measles will be making a comeback, even in the United States, even in Europe? So the UK isn't, a safe haven if you're undervaccinated or unvaccinated for measles.
Yeah, and I think that's a great point. Some of the more severe things, I mean, the general illness is fever and a rash and feeling bad and having maybe a runny nose and that type of thing. There's a couple of other physical exam findings in the oral pharynx and whatnot that docs will know about, but it can cause an encephalopathy and it can, as you said, lead to death. It's amazing to me how history isn't a good enough teacher for some folks, and that they have to see it to get reawakened to it. That seems to be a flaw that we're experiencing. Um, is it your sense that every most of these outbreaks are due to people who didn't get vaccinated, especially young people?
Yeah, so the vast majority of cases in the United States are people who are uh, undervaccinated or unvaccinated and have acquired it from an imported case. So typical scenarios are, somebody goes to Europe, they're unvaccinated or undervaccinated, they get measles, they come back, they spread it to other people, or a visitor from the say the Philippines, as in the outbreak in Disneyland in California a few years ago, comes to California. Um, a lot of people get measles because there are pockets in communities right now, as people may know, where there is very low vaccination rates, and the vaccination rate in kindergartners, which is probably very concerning to many people, is dropping over time. So it's for the first time dropped below the magical number of 95%. 95% is a really important number because it's the number we really need to ensure herd immunity, because measles finds pockets of vulnerability. And if we're over 95%, we can kind of protect those pockets. But now everybody's at risk because that herd immunity is compromised.
Yeah, and the vaccine is given with the mumps and rubella, so it's MMR still, right? And it's a live vaccine of sorts. And for people my age in their 60s and older, um, most of us had measles, the actual disease, and so our immunity is generally pretty good unless it gets immunocompromised in some kind of way. What about people who got, let's say in their late 40s, who got the MMR vaccine? Do they need a booster at some point, or are they okay?
At this moment, they don't need a booster. But again, all the people with partial immunity or waning immunity or no immunity, thinking of immune compromised hosts, they are again protected from the vast majority of people who have immunity. As that immunity drops, guidelines may change because right now we don't check titers unless you're a healthcare worker and you don't have vaccination records. But we relied on the strength of the people around us. So all of these guidelines may change over time if our vaccination rates go down.
Yeah, it's kind of a scary thought. And a lot of this, at least seems to me, has come from a spirit of anti vaccination. They're called anti vaxxers, um, and all kinds of misinformation, actually wrong information. That's too kind a word. It's actually wrong information about vaccines. And looking at the relative risk benefit, it started with COVID because for whatever reason it became a political football to say, well, I don't believe anything the scientists say, and the vaccines are evil and they cause death and a lot of things along that lines. But in the course of that, it seems to have a spreading effect to all vaccines and parents not vaccinating their kids. Um, is that your sense? I know for is that your sense of what's happening?
Well, there are two things happening. One, of course, is the drop in access during the early part of the pandemic, but that's kind of waning over time. And what you're left with is, as you pointed out, the misinformation, disinformation, probably catalyzed by the whole political discourse over the COVID vaccine, bleeding over into other vaccines that have nothing to do with COVID or mRNA shots. And it was a platform in which a lot of people jumped on, and that metastasis is really concerning to a lot of people. We've seen now, I think if you look at the data, the largest drop in sustained drop in childhood immunizations for more than 30 years. And if this continues, it's going to lead to a lot more vulnerable people who relied again on the herd immunity.
Yeah, I think it's worth going back and saying that issue of herd immunity again. In other words, if you have a person who may have a weakened immune system, even if they had been vaccinated as a child, and now they're in their 40s or 50s, but their immune system's weakened, they didn't have enough measles around them to pick it up. So even though they might be more susceptible, they aren't exposed. But if more and more people are not vaccinated and they pick up the infection, bring it into that room that you were describing, and then the more susceptible person walks in, they pick it up and get hit by it, and it just kind of continues to spread. So it's kind of protecting ourselves and protecting our neighbor when we participate in these vaccine programs.
Definitely. And then, you get into the whole slew of complications that you described, which could be even more severe in people who are immune compromised, people who are pregnant, and affecting the unborn child as well. So, again, the pneumonia, the encephalopathy, even the long COVID version of measles, which is called SSPE, where you can get it up to 7 years after, likely due to persistent virus. So there are a lot of analogs to some of these other viruses that we're really studying very deeply right now.
Exactly. So, in our few minutes left here, are there any other emerging infections that you've got your eye on that you'd like to mention?
Yes, I mean, I think that, of course, there's avian flu that everyone is worried about right now. It gives us an opportunity to really mobilize and create that infrastructure in case something is going to happen, that human to human transmission. I think it probably will happen at some point. The writing is on the wall. The last influenza outbreaks have all had avian origins. So it's just a matter of time. So I think that is something that's taking up a lot of brain space in us, in the CDC and the FDA right now, given the dairy workers protecting those vulnerable people, preparing the vaccines. I think other old friends are coming back a lot. We've known about RSV in the last couple of winters. Luckily, we have a vaccine for that right now. And some people, norovirus has made a big raging comeback. Um, Pertussis is all the rage in some communities. So it is the era of infectious diseases again, and I think the public is very sensitized to infectious diseases. It behooves all of us to really communicate sensitively, meet people where they are, and continue to have that discourse. And again, bleeding over the politics of COVID into all of these other prevention has really been something that nobody anticipated.
Right, and I was heartened to hear it makes sense that there are people working on an avian flu vaccine for this emerging one that seems to only be in the animal community right now. And though there have been a couple of human cases, it seems direct one to exposure,
Hmm.
especially to cows or cow milk and that type of thing. And what you're expressing is a concern that it'll break out and have human to human transmission, which hasn't happened yet, but that's, as you said, how a lot of these epidemics begin, first from animal to humans, and then once it goes human to human, the barn door is open, pun intended, and it goes from there. So there are vaccines being developed now.
Yes, so we have traditional protein-based vaccines. There are almost 5 million in production right now, waiting in the wings. And most excitingly, Moderna and potentially Pfizer in the future have the technology. Moderna actually has a contract now to do mRNA vaccines of flu. And the reason why that's exciting is that it's much more nimble. So if you have a mutation in H5N1 that suddenly jumped to allow human to human transmission, I think the mRNA vaccines can allow that cut and paste of that new code and mobilization within a matter of months or weeks to create a vaccine that's tailor made, and also other influenza vaccines of pandemic potential.
Yeah, it is amazing that technology that we kind of take for granted, but the notion that you have an mRNA vaccine that you can just shuttle a vector right in there and off it goes. And while you'd want to prove obviously safety and efficacy with every single vaccine you create, so far it translates pretty well and works really, really well for us. Any final thoughts before we wrap up?
Well, I think in terms of the brave new world of infectious diseases, I think it again is our responsibility to communicate sensitively, figure out where people are. I think we have to relearn all of these old infectious diseases like measles, um, and I think be activists in our own way. I think to dispel some of these rumors. A lot of infectious diseases is now infused with politics, and I think um, ID docs have always been activists, but we need to continue to be activists in these brave new worlds of pandemics, one after the other.
Yeah, we're also generally educators, usually at our medical schools, like you've received those awards for teaching at UCSF. I think that type of activity happens all over the country and the world for that matter, and so we have to continue to educate not only our students and young doctors, but also the general public. Peter, thank you for being with us. This was a great uh, podcast that covered an awful lot of material in a short period of time. Very grateful for your time.
Thanks so much, Mike. And I'm surprised we didn't talk about show tunes, your favorite thing, but maybe that could be for another podcast.
Right. Emerging infections, the musical. Yeah, we'll do that. Okay. Thanks, Peter.
Thanks so much, Mike.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.